Overall, I think that the biggest impact that we've had see change how we manage MDS has been the broader application of mutation testing into the diagnosis and prognosis of MDS, and a little bit now into treatment selection. It has helped us define who is really a high-risk patient, meaning that their disease is not going to be stable and will probably cause problems within a year or two, and distinguish them from patients who are really going to live with their disease for a long time, years and years, and whose disease, while it may be a burden to them, is more of a chronic challenge. And I think that distinction, that molecular definition of these groups and also subsets of disease has helped us really identify goals for a given patient. So if you're going to live with your disease for a long time, ascertaining what are the problems in that setting, most often it's going to be anemia, and how can we address that anemia over a long period of time. Conversely, if you have disease that really is going to cause you problems within the next year, how do we address your MDS right away? How do we say, well, what is the goal that we should be pursuing? Are we trying to cure you of this? Are we trying to manage the complications of it? Do we want to try to treat it to get a better response and prolong your life? And so I think that overall, the biggest impact that we have has really been the uniform incorporation of that testing into how we manage patients. High-risk MDS remains a real challenge for us all. It has shared characteristics of both AML, but then also I think it's easy to forget that these patients have a bone marrow failure syndrome, and we really need their blood counts to also improve. Everybody in the field is really waiting for Verona to read out. This is, again, the study of azacitidine combined with venetoclax versus azacitidine alone, and it should hopefully give us some sense of whether augmenting therapy by adding venetoclax has a role in improving the response rate and survival of patients with MDS. No matter what information we gather from that trial, I think it would give us a good understanding of A, how do we molecularly select patients for a specific therapy, and B, how do we choose an appropriate goal for a given patient. One thing that we don't know very well in a modern era is if you have high risk by molecular features, but otherwise reasonable blood counts or lower blasts, does treating you with a more intensive therapy to try to get rid of those mutations result in improved overall survival and benefit to you clinically? And I think that that is one thing that we'll really gather from this large randomized trial. It will also set the backbone for what we want to do for any patient with high-risk MDS. So if adding venetoclax becomes a standard of care, we'll probably be able to identify some patients who really benefit the most from that, and then we can work with that group to then further advance their outcomes, as well as we'll probably be able to identify patients who really don't benefit so much from that combination. And if those patients really need a new therapy, how can we selectively pick patients to try to perhaps get a targeted therapy or move the needle for them in a different way? And so I think that the whole field is really eagerly anticipating what readout will come. It's clear, that some types of MDS really do have AML-like features. And so regardless of the endpoint, I think there will be a role for venetoclax in some patients. Same way that we've learned in AML, there are some patients, for instance, p53 mutant disease, where the addition of venetoclax, while it might slightly increase the response rate, doesn't really prolong that response. And so you really have to ask yourself, what is it adding? P53 disease, we'll see if that plays out the same way in MDS. And so there may be subgroups where we really want to focus in a different way. And so I think that we'll be able to use this data really to advance how we tune our treatment for patients. It will also give us a sense, I think, one big question in the modern era is when patients are transplanted, how does that affect trial outcomes? And also, how do we incorporate that into our treatment algorithm? Do we try to treat to a response prior to transplant in MDS? Is there a time where we should really just move into transplant? And so that's probably the biggest study in MDS. There are other agents that are kind of early phase trying to look at new targets in the space. But once we have this sense of whether venetoclax will become part of our backbone uniformly, that will really open the floodgates for kind of what we move to next. I think that the other area that will be of interest is can we use therapies that have more of a blood count improvement effect and higher risk disease? Can we incorporate those into the treatment of higher risk patients? Can we try to get blood count improvement, which is arguably just as important for those patients, in addition to perhaps suppression of blasts or other more traditional outcomes with advanced care? As with any tool, molecular testing really has advanced how we assess what's likely to happen to a patient. A big need, however, is a prospective validation of whether a treatment strategy works well with this new molecular category. So we're still stuck with therapies that were developed way back in the days of the IPSS, so 20 plus years ago, as well as some therapies now which use the IPSSR to select lower or higher risk patients. And so when we think about who's likely to benefit from a treatment, we really are using models of risk stratification or patient selection that predated the widespread use of molecular profiling. I think when we now have these tools at our fingertips and are using molecular testing on every patient, an unknown question is how that molecular risk interplays with treatment response. And so I'm hopeful that with these studies, including some of the phase 3 studies that have recently finished, we can get a better sense of those patients who benefit the most from treating molecular risk, even if, say, they don't have high blasts or they don't have low blood counts. And those patients who really, the blasts and blood counts should drive your treatment decision rather than just purely molecular risk. And so while it's clear that molecular risk gives us a sense of disease stability and gives us an understanding of which patients are likely to need something, that their disease won't just stay quiet, I think we are still learning how best to use treatments. The one area where I am kind of uniformly incorporating molecular risk into my treatment decision-making right now is that discussion with transplant. When I have a patient who has high molecular risk, while deciding on chemotherapies is still kind of a moving target in a discussion with them, patients who have high molecular risk, I really am getting them to meet transplant early. It's exciting to see some new drugs be approved for MDS in the last couple of years, and it's exciting to see how we really are addressing this disease and its heterogeneity in a different way. I think that one of the challenges in this disease is that it affects older patients. Most people are in their 70s or 80s. Even if they have excess blasts or high molecular risk, the day-to-day problems that they face are usually around blood counts, getting infections, needing transfusions, risk of bleeding. And many of our therapies and how we design our studies are really anchor on reduction in blasts, similar to AML, especially in high-risk disease. And I think that we've got new response criteria that we've recently developed over the last few years. Those are being prospectively assessed still. And we'll probably need to have ongoing refinement. But one thing that I think that they capture is the importance of blood count improvement, even in patients with high risk. And so I think that when we work on drug development, we really need to pay attention to these patients who, yes, their blasts reduced, but also they have transfusion-free intervals, or they're coming to clinic less, or they're able to avoid infections and they have fewer hospitalizations for that. How do we actually impact patients' quality of life while we're treating them? And using those criteria will help us select drugs early in development that might show signs of blood count improvement that we can really advance to a broader patient population. When we're treating patients to cure them, transplant still plays a role, but for many patients, that's not going to be an option. And so being able to give them maybe a non-curative therapy, someday hopefully a curative chemotherapy, but something that will prolong their life. We also want to make sure that their lives are improved. And so a lot of that means not seeing me. So how can I keep you out of my clinic? How can I have you do more of the things, travel or see family, or all these things that coming into clinic really takes away from? And so I think that is probably the area that we, with new response criteria and with kind of ongoing efforts to look at, especially in low-risk disease, can we trickle over into high-risk disease for like blood count improvement or some of the therapies that are trying to get transfusion independence, those endpoints matter for high-risk patients too. And so I hope that that is kind of the direction that our field goes, because I think that selecting drugs that help improve blood counts and improve the bone marrow failure component of MDS, in addition to reducing blasts or cytoreduction, those are where we'll be able to really move the needle.